Primary myelofibrosis. Primary myelofibrosis, chronic primary myelofibrosis. So, what are the other designations? So, what are the other designations for primary myelofibrosis? So, these include idiopathic myelofibrosis, also agnogenic myeloid metaplasia, or myelofibrosis with myeloid metaplasia. So, chronic primary myelofibrosis. So, what are the other designations for this? So, this include idiopathic myelofibrosis. It is also called as agnogenic myeloid metaplasia or myelofibrosis with myeloid metaplasia. So, what is this disorder? It is a clonal hematopoietic stem cell disorder. It's a primary myelofibrosis is a clonal hematopoietic stem cell disorder. So associated with mutations. So what are the mutations? JAK2, MPL or CALR. And so what are the mutations associated with primary myelofibrosis? So these are JAK2, MPL or CALR, and this is characterized by marrow fibrosis. So what happens in the marrow? There will be a marrow fibrosis, there will be extramedullary hematopoiesis, and there will be splenomegaly. So what are the mutations in this primary myelofibrosis? JAK2, MPL or CALR. And what is this characterized by? Marrow fibrosis, extramedullary hematopoiesis, and splenomegaly. Primary myelofibrosis, it is the least common myeloproliferative neoplasm, and establishing its diagnosis in the absence of a specific clonal marker is difficult, because myelofibrosis and splenomegaly, they're also features of both polycythemia vera and chronic myeloid leukemia. So it is the least common myeloproliferative neoplasm. And establishing the diagnosis of this disorder in the absence of a specific clonal marker is difficult. Why? Because myelofibrosis and splenomegaly, so these features are also seen in other myeloproliferative neoplasms like polycythemia vera and chronic myeloid leukemia. Furthermore, myelofibrosis and splenomegaly, they also occur in a variety of benign and malignant disorders, and many of which are amenable to specific therapies which are not effective in primary myelofibrosis. So if we take this myelofibrosis, that is marrow fibrosis and also splenomegaly. So these myelofibrosis and splenomegaly, they occur in a variety of benign and malignant disorders. So they will be amenable to specific treatment, but this is not effective in primary myelofibrosis. In contrast to other myeloproliferative neoplasm and so-called acute or malignant myelofibrosis, which can occur at any age, primary myelofibrosis primarily afflicts men in their sixth decade or later. So these are the disorders causing myelofibrosis. So apart from this primary myelofibrosis, primary myelofibrosis, so this affects men in their sixth decade or later. So what are the other disorders which can cause this myelofibrosis? So examples of this include acute leukemia. So it could be a lymphocytic, myelogenous or a megakaryocytic leukemia, or it could be a CML, which can also cause myelofibrosis and splenomegaly. So apart from acute leukemia, CML, hairy cell leukemia, Hodgkin's disease, primary myelofibrosis, lymphoma, multiple myeloma, myelodysplasia, metastatic carcinoma, polycythemia vera, systemic mastocytosis. So all this will cause myelofibrosis. So non-malignant include HIV infection, hyperparathyroidism, renal osteodystrophy, SLE, tuberculosis, vitamin D deficiency, thorium dioxide exposure, and gray platelet syndrome. So, what are the non malignant disorders which cause myelofibrosis? HIV infection, hyperparathyroidism, renal osteodystrophy, SLE, tuberculosis, vitamin D deficiency, thorium dioxide exposure, and gray platelet syndrome. So, what is the etiology? So, there are non-random chromosome abnormalities. So, what are the non-random chromosome abnormalities? So, these are 9p, 20q minus, 13q minus, trisomy 8 or 9, or partial trisomy 1q. So, these are common in primary myelofibrosis, but no cytogenetic abnormality specific to the disease has been identified. So, there are non-random chromosome abnormalities in this disorder. So, what are these non-random chromosome abnormalities? So, these are 9p, 20q minus, 13q minus, but there is no cytogenetic abnormality which is specific to the disease. And if we take this JAK2 V617F, so this is present in 55% of primary myelofibrosis patients. So, JAK2 V617F. So, this mutation, it is present in how many percent of PMF patients? It is present in 55%. And there is also mutations in the thrombopoietin receptor. Okay, so this is MPL. So, this mutation, so this occurs in 4% of the patients. Okay, JAK2 V617F in 55%, MPL mutation in 4%, and most of the rest have the mutations in the calreticulin gene. So this calreticulin gene, so this alters the carboxy terminal portion of the protein, permitting it to bind and activate MPL. So that is thrombopoietin receptor. The degree of myelofibrosis and the extent of extramedullary hematopoiesis are not related. So there is a myelofibrosis. So what should happen? Extramedullary hematopoiesis should happen. So the degree of myelofibrosis and the extent of extramedullary hematopoiesis, so these are not related. Fibrosis in this disorder. So why fibrosis is occurring in this disorder? Because of overproduction of transforming growth factor beta and tissue inhibitors of metalloproteinases. While osteosclerosis, it is associated with overproduction of osteoprotegerin and osteoclast inhibitor. So why fibrosis is occurring in this disorder? Because of overproduction of what is overproduced transforming growth factor beta and tissue inhibitors of metalloproteinases. So while osteosclerosis, it is associated with overproduction of osteoprotegerin and osteoclast inhibitor. Marrow angiogenesis occurs due to increased production of vascular endothelial growth factor. Marrow angiogenesis. So marrow angiogenesis occurs due to increased production of vascular endothelial growth factor. So VEGF growth factor, it is essential for marrow angiogenesis. Importantly, fibroblast in primary myelofibrosis or polyclonal and not part of the neoplastic clone, but can be induced by it to produce inflammatory cytokines. So if we take the fibroblast in primary myelofibrosis, they are not monoclonal. They are polyclonal and they are not part of the neoplastic clone, but this can be induced by it to produce inflammatory cytokines. So fibroblasts produce inflammatory cytokines. So what are the clinical features? No signs or symptoms are specific for primary myelofibrosis. Many patients, so they are asymptomatic at presentation. And disease, how is it detected? By discovery of, so there will be a splenic enlargement, or what will be there? Abnormal blood counts will be there during a routine examination, because no signs or symptoms are specific for primary myelofibrosis. In contrast to its companion myeloproliferative neoplasm, night sweats, fatigue, and weight loss are common presenting complaint. So if we see the blood smear, it will show the characteristic features of extramedullary hematopoiesis. So what characteristic features? Extramedullary hematopoiesis features on blood smear. So there will be teardrop cells, nucleated red cells, myelocytes, promyelocytes, myeloblast may also be present. Anemia usually mild initially is common. So in smear what are seen? Teardrop shaped red cells. Apart from that, even nucleated red cells are also seen. And myelocytes, promyelocytes, myeloblast may also be present. Anemia usually mild initially, it is common, whereas the leukocyte and platelet counts, they are either normal or increased, but either can be depressed. Mild hepatomegaly may accompany the splenomegaly but is unusual in its absence. Isolated lymphadenopathy should suggest another diagnosis. Mild hepatomegaly can also be seen. It can accompany the splenomegaly. If there is a lymphadenopathy, isolated lymphadenopathy, it should suggest another diagnosis. And both serum LDH and alkaline phosphatase levels can be elevated. So what are elevated? Serum LDH and alkaline phosphatase levels can be elevated. Marrow, it is usually inaspirable due to the myelofibrosis. So what has happened in the marrow? There is a fibrosis, so it is inaspirable. And if we see bone x-rays, so they will reveal osteosclerosis. On x-rays of the bone, so this will reveal osteosclerosis. Exuberant extramedullary hematopoiesis can cause ascites, portal, pulmonary or intracranial hypertension, intestinal or ureteral obstruction, pericardial tamponade, spinal cord compression or skin nodules. So, exuberant extramedullary hematopoiesis. Exuberant extramedullary hematopoiesis. So, this can cause ascites, portal, pulmonary or intracranial hypertension, intestinal or ureteral obstruction, pericardial tamponade, spinal cord compression or skin nodules. Splenic enlargement can be sufficiently rapid to cause splenic infarction with fever and pleuritic chest pain. So splenic enlargement is there. So this can be sufficiently rapid, so to cause splenic infarction with fever and pleuritic chest pain. Hyperuricemia and secondary gout may ensue. Diagnosis. While the clinical picture described above is characteristic of primary myelofibrosis, all of these clinical features can be observed in polycythemia vera or chronic myeloid leukemia. And massive splenomegaly commonly mask erythrocytosis in polycythemia vera, and reports of intra-abdominal thrombosis in primary myelofibrosis most likely represent instances of unrecognized polycythemia vera. In some primary myelofibrosis patients, erythrocytosis has developed during the course of the disease. Furthermore, because many other disorders have features that overlap with primary myelofibrosis but respond to distinctly different therapies, the diagnosis of primary myelofibrosis is one of exclusion, which requires that the other disorders, so whichever we have discussed, all those disorders have to be ruled out. And intra-abdominal thrombosis in primary myelofibrosis, it most likely represent instances of unrecognized polycythemia vera. In some primary myelofibrosis patients, what has occurred? Erythrocytosis has developed during the course of the disease. And the presence of teardrop shaped red cells, nucleated red cells, myelocytes, promyelocytes, so this will establish extramedullary hematopoiesis. So which will establish extramedullary hematopoiesis? Teardrop shaped red cells, nucleated red cells, myelocytes and promyelocytes. So this establishes the presence of extramedullary hematopoiesis, while presence of leukocytosis, thrombocytosis with large and bizarre platelets and circulating myelocytes suggests the presence of a myeloproliferative neoplasm as opposed to a secondary form of myelofibrosis. So what are the features that suggest extramedullary hematopoiesis? So these are teardrop shaped red cells, nucleated red cells, myelocytes, promyelocytes. So all these establish the presence of extramedullary hematopoiesis. If there is a leukocytosis, thrombocytosis, and large and bizarre platelets and circulating myelocytes, this suggests the presence of a myeloproliferative neoplasm as opposed to a secondary form of myelofibrosis. So what happens to marrow? It is inaspirable due to increased marrow reticulin. But marrow biopsy, so this will reveal a hypercellular marrow with tri-lineage hyperplasia and in particular increased number of megakaryocytes in clusters with large dysplastic nuclei. So what happens to marrow? Marrow, it is inaspirable. So due to increased marrow reticulin. But marrow biopsy, so this will reveal a hypercellular marrow with tri-lineage hyperplasia, and in particular what will be there? There will be increased numbers of megakaryocytes in clusters with large dysplastic nuclei. However, there are no characteristic bone marrow morphological abnormalities that distinguish primary myelofibrosis from the other myeloproliferative neoplasms. Splenomegaly due to extramedullary hematopoiesis, it may be sufficiently massive to cause portal hypertension and variceal formation. So if we take splenomegaly, which is due to extramedullary hematopoiesis, it may be sufficiently massive, so this will cause portal hypertension and variceal formation. In some patients, exuberant extramedullary hematopoiesis can dominate the clinical picture. Few patients, what will happen? This exuberant extramedullary hematopoiesis, so this can dominate the clinical picture. An intriguing feature of primary myelofibrosis, it's the occurrence of autoimmune abnormalities such as immune complexes, anti-nuclear antibodies, rheumatoid factor, or a positive Coombs test. So what is the intriguing feature of primary myelofibrosis? So there is a occurrence of autoimmune abnormalities. So what are these autoimmune abnormalities? Immune complexes, anti-nuclear antibodies, rheumatoid factor, or a positive Coombs test. So whether these represent a host reaction to the disorder or involved in its pathogenesis, it is unknown. And cytogenetic analysis of the blood, it is useful to exclude CML and for prognostic purposes, because the development of complex karyotype abnormalities, it portends a poor prognosis in primary myelofibrosis. So if there are complex karyotype abnormalities, so this will portend a poor prognosis in primary myelofibrosis. So cytogenetic analysis of the blood is useful. So this is both to exclude CML and also for prognostic purposes. And for unknown reasons, the number of circulating CD34 plus cells is markedly increased in primary myelofibrosis. So what happened to number of circulating CD34 plus cells? So these is markedly increased compared to other myeloproliferative neoplasms, unless they too develop extramedullary hematopoiesis. And importantly, 55% of primary myelofibrosis patients, like patients with its companion myeloproliferative neoplasms, they express the JAK2 V617F mutation, often as homozygotes. Okay, so what percentage of primary myelofibrosis patients develop this JAK V617? So this is 55%. So these patients, they are usually older and they have higher hematocrits than patients with MPL or CALR mutations. And primary myelofibrosis patients expressing an MPL mutation, they tend to be more anemic and have lower leukocyte counts than JAK2 V617F positive patients. So if BMF patients, if they express the MPL mutation, they tend to be more anemic and they have lower leukocyte counts than JAK2 V617F positive patients. And somatic mutations due to deletions type 1 or insertions type 2 in exon 9 of CALR have been found in a majority of patients with primary myelofibrosis who lack mutations in JAK2 or MPL. So if they don't have any mutations of JAK2 or MPL, what mutations are seen? Somatic mutations. So due to deletions type 1 or insertions type 2 in exon 9 of CALR. So they have been found in a majority of patients with primary myelofibrosis who lack mutations in either JAK2 or MPL. In some studies, type 1 mutations, the most common CALR mutation in primary myelofibrosis, it had a survival advantage compared to JAK2 or MPL mutations, but not with respect to leukemic transformation. So if we take this type 1 mutations, which is the most common CALR mutation in primary myelofibrosis, so they had a survival advantage compared to JAK2 or MPL mutations, but not with respect to leukemic transformation. And primary myelofibrosis patient who lack a known MPN driver mutation, so they appear to have the worst prognosis. So if we take primary myelofibrosis patients, they lack a known MPN driver mutation, they appear to have the worst prognosis. So complications. So survival in a primary myelofibrosis patient, it varies according to the specific risk factors and diagnosis, but it is shorter than in polycythemia vera and essential thrombocytosis. So survival in primary myelofibrosis, no? So this varies according to the specific risk factors. The natural history of primary myelofibrosis, it's like a marrow failure. There will be a transfusion dependent anemia, increasing organomegaly because of extramedullary hematopoiesis. And as with CML, so this primary myelofibrosis, so this can also evolve from a chronic phase to a accelerated phase with constitutional symptoms, and there will be a marrow failure. And 10% of the patients, so they will transform from chronic to an aggressive form of acute leukemia. So for this therapy, it is usually ineffective. And what are the additional important prognostic factors for disease acceleration? So if there are complex cytogenetic abnormalities, thrombocytopenia and transfusion dependent anemia. So these are the additional important prognostic factors for disease acceleration. So these include thrombocytopenia, complex cytogenetic abnormalities, and if there is a transfusion dependent anemia. So these patients have important factors for prognostic factors for disease acceleration. Mutations in the ASXL1, EZH2, SRSF2 and IDH1 or 2 genes have been identified as risk factors for early death or transformation to acute leukemia, as have complex cytogenetic abnormalities, and they have proved to be more useful for primary myelofibrosis risk assessment than the clinical scoring system. So what are the mutations? Mutations in the ASXL1, EZH2, SRSF2 and IDH1 or 2 genes. So they are the risk factors for early death or transformation to acute leukemia, as have complex cytogenetic abnormalities, and they have proved to be more useful for primary myelofibrosis risk assessment than clinical scoring systems. So here you can see the teardrop shaped red blood cells here. um, So this marrow cavity, it is replaced by the fibrous tissue composed of reticulin fibers and collagen. So if it is a primary hematological process, it is called as myelofibrosis. When the fibrosis, if it is due to a tumor or a granulomatous process, so it is called as myelophthisis. When the fibrosis is secondary to a tumor or granulomatous process, so this is called as myelophthisis. So that's about the clinical features and diagnosis of primary myelofibrosis.